Welcome on this new webinar hosted by CMRAD. So tonight we will be featuring Professor Patrice Jissendi from Brussels, who will take us through a neuroradiology case from start of diagnosis to final diagnosis. At the end of the session, in the post, in the chat, I will post a link to the different courses which already happened in the last few weeks. So this one is going to be the fourth case. And the magic about CMRAD is that you will be able to watch the video and look at the picture as if it was on your own PACS. So any further ado, I give the word to Professor Patrice Jissendi.
Thank you, Jean-Baptiste. Good evening, everyone. Dear colleagues and friends, it's my pleasure to welcome you to this new webinar. And tonight, we will be dealing with a case that raises the matter of lesion topography. The final diagnosis was histologically proven. And as always, before we go through the case, I would like you, please, to follow the case step by step and to look at the series if you have your own window on CMRAD platform. In the multiple choice question, you will have only one correct answer to choose. And as you know, it's anonymous. So please just click on the answer you think it's correct. Thank you thanks to JB for handling the poll. And for the first time, we will have a final quiz by the end of the presentation. So stay alert. Then let's get started. Let me share my screen. Okay, as you can see on the screen now, this is the clinical story of the patient. Shaken to the core, a 45-year-old woman with no medical history. She presented herself to the emergency after a sudden malaise and strange feelings like shaken to the core and fall in the night when going to the bathroom. She had a short loss of consciousness. And she also reported having experienced such feelings in a couple of months ago. And she also reported to have recurrent headaches in the last 2 months. The physical and neurological examination were normal. So I will go now to the review mode window. Give me a second. Okay, there we go. So these are images obtained from the non-enhanced CT, head CT. And these are actual images, sagittal reformatted images and coronal images. So let's go straight to the point. In the posterior fossa, nothing was found except this area of spontaneous hyperdensity, which was thought to be some focal hemorrhage. We can see it on this plane, on the sagittal plane, but it looks a bit strange on the coronal plane because it looks like roundly shaped, and it's hard to tell if it's part of the adjacent mass, because there is a mass that can be obviously seen here at the level of the third ventricle, centrally located. With, let me click on this one and zoom out and maybe change the window. And you can see that on the floor, it seems that this hyperdensity is on the floor of the mass, which is growing up supratentorally and really centrally located. And there is kind of various densities within the mass with hypodense area, cyst-like, area at the level, at the anterior and left part of the mass. But you can see that there is no obvious calcification within the mass. And here on the sagittal plane, you can see again this hyperdense area. And on the coronal plane, you can see the mass effect on the ventricles with enlargement and dilatation of the lateral ventricles and the temporal horns of the ventricles. So once again, this is just a calcification of the choroid plexus and maybe, but it's not part of the mass itself. So I think we will get more information by looking at the MRI. And then we can start with axial T1. And we will put together axial T1, T2 gradient echo to see what's going on in the area that was looking hyperdense on CT, and then coronal T2. Okay. What do we see here? At the level of the interpeduncular cistron, we can see that there is no spontaneous hyper T1 signal at that area, and even within the mass looks a hypo T1 globally with some cystic area that can be seen here with a hypo signal looking like flute, but it's less hypo signal than the CSF within the ventricles. And maybe one would expect to see some dark signals at that area. And this is what happens. We have a dark signal here, but it looks a little bit smaller than what we saw on the head CT. And then if we get to that place using the coronal T2 images, we can see that there's a huge mass, maybe going through the third ventricle, but growing up to the foramina of Monro with some cyst-like parts anteriorly. And there is a displacement of the chiasma here. And it looks globally hyper signal on T2 images. Then we can see what's going on the diffusion images. So the mass is really centrally located, and there is no hyper signal on diffusion images except this area of the abnormality that is suspected as being a hemorrhagic spot. So obviously, just take a look at the ADC map. So there is no obvious diffusion restriction that can suggest a high cellularity within the mass, right? It seems that diffusion is increased all over the mass. And we can then take a look at gadolinium enhanced images. And what we see is a strong enhancement of the solid part of the tumor, and also some enhancement, ring enhancement of the cystic part of the tumors. But the tumors is mostly composed of the solid part, which is the major part of the tumor, and there are some cysts at the periphery of the tumor. And the same thing can be seen on reformatted coronal T1 with gadolinium. As you can see here, the enhancement is very strong, and it goes a bit through the foramina and Monroe on the left. Then we can also take a look at the perfusion images. You know, ISL is used to get some tissue hemodynamics without a contrast in media injection. It's based on the labeling of the red blood cells within the vessels. And then what we get here is the signal of the ASL. And if you remember the images I sent with the invitation, you see there the CBF map from the ASL fused with the T1 gadolinium. And you can see that the CBF is increased in some parts of the tumor. And looking at the image, the fused image that I sent before, what is interesting to notice is that only some part of the tumor shows an increased CBF. So the vascularization of the tumor is not homogeneous, but heterogeneous. And this is an information to keep in mind. Lastly, we can take a look at spectroscopy, because spectroscopy was performed in this case. And what we see here is that there is a huge peak in the frequency band going from 0.9 to 1.5, which includes lactate peak and lipid peaks. Also, there's a decrease in Na with inversion in Na-choline ratio, elevated choline, which suggests that we're dealing with a tumor. That's all. But we will see if we can get some clue to the diagnosis using the lactate and lipids peak. So please, JB, can you launch the first poll with the differentials? So given the clinical story and the CT and MRI findings, what is your diagnosis? Intraventricular CNS lymphoma, central neurocytoma, craniopharyngioma, subependymoma, choroid plexus papilloma, or chordoid glioma of the third ventricle. Okay, so the majority of you have chosen craniopharyngioma. And some central neurocytoma, subependymoma, choroid plexus papilloma, chordoid glioma, all these tumors are centrally located in the CNS, in the intracranial space. But let us see some other features. Maybe I didn't show you the FLAIR images. Okay, we can take a look at the FLAIR images and see something more. Can you see the edema surrounding the lesion, the cerebral peduncles, and the hypothalamic area? It extends to the parenchyma around the subependymal layers of the third ventricle. And another thing is, if you look at the sagittal T1 gad, you can see that the pituitary stalk is there, the diaphragm is respected, and the suprasellar cistern is also free. And so given that the first key feature of the lesion is its location, among the previous list, only 3 possible diagnoses remain. Then you have a second chance for those who did not choose the correct answer. JB, can you please launch the second? So the 3 that remain are intraventricular CNS lymphoma, craniopharyngioma, chordoid glioma of the third ventricle. It's nice to see live the evolution of the votes. Okay, the final result shows that some of you have changed to chordoid glioma of the third ventricle, which is really the first differential diagnosis of the final diagnosis. So it's not that one, but it's really similar in MRI features. It shows the same features as the final diagnosis. So let's move on, and I will now stop sharing the screen and move to the presentation. So this is the final diagnosis given by histology. The tumor was completely resected, and it proved to be a third ventricle craniopharyngioma of papillary type. And talking about craniopharyngiomas, I will say CPs in general. They are classified by the World Health Organization as grade 1 tumors, and they are divided into adenomatous craniopharyngiomas, which account for 90% of all craniopharyngiomas, and papillary craniopharyngiomas for the rest. And craniopharyngiomas are thought to arise from neoplastic transformation or metaplastic transformation of ectopic embryonic remnants of either the craniopharyngeal duct or Radke's pouch. And you have on this table a differentiation between craniopharyngiomas in general that are found in childhood and adulthood with 2 age for the peaks. It peaks at between 10 and 14 years in childhood, and between the 4th and the 6th decades in adulthood. In comparison with third ventricular craniopharyngioma that occurs almost always in adults. The location is central, but in CPs in general, the location is supracellular, but can extend to the intracellular space. And but in CPs, it's always a supracellular with intraventricular extension. And on the next slide, I will make the difference between intraventricular intrinsic craniopharyngioma and intraventricular non-intrinsic craniopharyngiomas. The solid part is found in both tumors, but in third ventricular craniopharyngioma, the solid part is the major part of the tumor, but in other craniopharyngiomas, the cystic part may be the majority of the mass. And the cystic part appears hyper on T1 images often because of the content of the cyst, and the cystic part will appear hypo to iso signal on T1 in the third ventricular CPs. There is no calcification found in the third ventricular CPs. In the contrary, there are almost always calcifications found in other CPs, and especially in adenomatous adamantinomatous craniopharyngiomas. The enhancement is strong in both cases, and with nodular and ring cysts like in CPs in general, but in the third CP craniopharyngioma, the enhancement is strong, but also very heterogeneous. And this is one of the key features when you're looking at the case. The pituitary stalk is also one of the clues to be considered because it's always involved in general in CPs, but not in third ventricular CP. So according to this paper, if we consider the central location of the tumor, we can make the difference between intrinsic third ventricular craniopharyngiomas and non-intrinsic craniopharyngiomas. In the first case, you have a displacement of the ependyma of the third ventricle by a tumor that arises in the same location, I mean, in the infundibulum of the third ventricle, but it arises beyond the ependyma of the third ventricle, and it pushes the ependyma and closes the third ventricle. But in this case, in the intrinsic third ventricle craniopharyngioma, you have a dislocation of the ependyma, and it crosses the ependyma toward the cavity of the third ventricle. So this is really different. And if by means of imaging, you can show the persistence of the ependymal layer or not, you will be able to make the difference. But in this paper, 5 criteria were described that can lead to the final diagnosis. The lesion is typically roundly shaped, and the location is retrochiasmatic. You can see clearly the pituitary stalk, and the optochiasmatic cistron is free. And there is a displacement of the mammillary body. The hypothalamus region is situated below the lower third of the tumor. When you have all these characteristics, you can make sure that you're dealing with a third ventricular craniopharyngioma. And the third ventricular craniopharyngioma is a rare tumor. It accounts for only 0.7% to 40% of tumors, and is really intraventricularly located. So one of the first differentials is the third ventricle chordoid glioma, which shows extremely similar features, except that there is no cyst associated with this one. And the topography matters because CPs show a high tendency to develop strong adhesions to adjacent tissues and structures. That is why when reading out those images, the radiologist should mention what are the structures adjacent to the tumor and what kind of relationship is there, what kind of adherence is there. So Prieto described 3 main characteristics found on MRI that could predict the adherence of the tumor to the adjacent structures and thus predict the feasibility of gross or partial total resection. So the surgeon needs to know what kind of adherence is there depending on the adjacent structure. First, you have to describe intracranial structures attached to the tumor, like third ventricle floor, third ventricle walls, like on these images, and the hypothalamus, if it's displaced or invaded, and also the adherence morphology. And in this case, the adherence morphology is circumferential. You also need to precise the strength of adhesion that is likely to be there. Here, the model is fusion. If you want to learn about other patterns of adhesion that are described in this paper, you can just download it. Prieto et al. It was published in 2018. On this sagittal image, you can see the strong relationship with the pituitary stalk here, but also with the top of the basilar trunk there. And also you see here the displacement of the fornix with kind of adherence to the pillar of the fornix there. So in sum, the third ventricle craniopharyngioma is a rare entity that should be recognized since it shows the typical features of suprasellar craniopharyngiomas, but is different in location and extension. Then, if you have stayed alert all the presentation long, you can get the final quiz. Please, Jean-Baptiste, can you launch it? So about craniopharyngiomas, which of the following statements is correct? CPs are typically central suprasellar tumors and always show calcifications. False or true? Adamantinus CP subtype does not show calcification and is often found in adults. A third ventricular mass in young adults with few cystic components and no calcification is likely a third ventricle craniopharyngioma. The exact location of a third ventricular craniopharyngioma is of concern for surgeons because gross total resection is always possible. So remember that adamantinous craniopharyngiomas are mostly seen in childhood, and that all craniopharyngiomas do not show calcifications, and that all CPs cannot undergo a gross total resection. Then you get the answer. Okay, can you end the polling, please? Thank you. So 55% have the correct answer, that a third ventricle mass in a young adult with few cystic components and no calcification is likely a third ventricular craniopharyngioma. I don't know if ASL can help and even spectroscopy, but if you have all those features that I have presented with heterogeneous enhancement, you can definitely make the diagnosis of third ventricular craniopharyngioma and even report the case because it's kind of rare. Thank you for your attention.
Professor Jissendi, thank you very much for this presentation. Maybe we can open a few minutes question and answers. So we can take the questions by chat, or if you feel like you can activate your microphone just to talk directly on the group. We are about 20, so it should be okay. So maybe I will start with the first question. Professor Jissendi, does it happen very often that you have such cases in your common practice, or is it quite a rare event?
No, it's rare. To tell you the truth, my first hypothesis, and in this case, was choroid glaucoma because it was really looking like, and after the surgery, the pathology disclosed that it was a third ventricular craniopharyngioma. And then I learned a lot about third ventricular craniopharyngioma by dealing with the case. And the patient was operated, the lesion was completely resected, and she's doing very well now. She was a journalist, and she got back to work a couple of months later. So if we give the surgeon the precisions he needs to plan the operation, the lesion can be completely resected and no radiotherapy is needed after surgery. So there's a question on the chat asking what was the hyperdensity on CT. Afterwards, we thought that the hyperdense density that we saw was a hemorrhagic spot within the lesion because she really had a head trauma. She hurted the wall in the bathroom with a head, and something was shaken in the head. So we think that it was kind of hemorrhage there because the densities were not close to calcification, the density we see in calcification areas, in calcified areas.
So what I will do, I am just posting to the chat, I'm posting a link to the collection of your different cases of the last few weeks. As for me, as an MSK radiologist, it's I'm very happy to have such courses, and it's still a lot to take. So I will have take a chance to look at the video again, and also be able to go through the case on the PAC system. So Professor Jissendi, thank you very much for this presentation. And what I can maybe say, if there are maybe questions coming later on or related cases, you can post your questions directly in the comments of the cases, which is already online, and the video of tonight's presentation will also be posted inside of the case.
Thank you. Have a good night.
Thank you very much. Bye-bye.
Bye-bye.